Hello, boys and girls. Last day we stopped our discussion on tuberculosis as the mode of spread. Today we are going to discuss the clinical features of tuberculosis. And before going to that, I want to say you something about the pulmonary and extrapulmonary tuberculosis. The tuberculosis occurring only in the lung parenchyma is to be considered as pulmonary tuberculosis. Tuberculosis occurring any other parts of the body is to be considered as extrapulmonary tuberculosis. You have to mind here two things. There is pleural effusion, there is fluid in pleural space, though it is part of the or inside the chest or the mediastinal lymph nodes, again this is also inside the chest. This is not to be considered as pulmonary tuberculosis. Both of the things are to be considered as extrapulmonary tuberculosis. Extrapulmonary tuberculosis can happen in any part of the body, any organ of the body. Pulmonary tuberculosis of all tuberculosis cases is about 55% to 60%. Extrapulmonary tuberculosis about 45 to 40% of the total pulmonary cases, tuberculosis cases. Now, why pulmonary region or the lung parenchyma is favored by the Mycobacterium tuberculosis? Why? It has got 3 points in your favor. One, as is a droplet-borne infection, so it is very easy to reach the lung parenchyma via inhaled breath. Second, lung is very highly vascular organ. Third, Mycobacterium tuberculosis is an aerobic organism and it requires much more oxygen than any other. So, all these three favors lung in favor of infection by Mycobacterium tuberculosis. Now, let us go to clinical features. Of clinical features, we first will consider the symptoms, then signs, then we will make how to make a diagnosis of tuberculosis, pulmonary or extrapulmonary. In between, we will go just touching through some important organs affected by tuberculosis. Now, symptoms. Very important symptom is low-grade fever and cough for more than 2 weeks. For more than 2 weeks. Another important feature is loss of appetite, loss of body weight, very important. Night sweating, important. Chest pain may occur, may not occur. Breathing difficulties may occur, may not occur. Hemoptysis, again, this is very important. In case of extrapulmonary tuberculosis, symptoms will depend on the system involved. Now, regarding hemoptysis, I want to tell you one point. That is not written in the book, but I have experienced this for the last 40 years, all throughout my practicing life, that the Mongoloid variety of Indian citizen, that is people mostly of the northeastern region, Sikkim and Nepal, they usually presents with hemoptysis, not with cough or fever, mostly with hemoptysis. You go for testing and they will come AFB positive in the sputum. Signs. Important sign is loss of body weight, pallor and emaciated look. This is very important, emaciated look. With experience, you will know how a TB patient, especially of the low socioeconomic group, looks. Clubbing in empyema, and actually there is not much signs as it is of insidious nature. You can get post-tussive rals, especially in apical region of the lung. Dullness on percussion if there is fluid in the pleural space. And amorphic breath sound over cavities. We'll just touch the extrapulmonary tuberculosis with a few important features. Now first we will go to pleural effusion. This occurs due to immunologic reaction of primary infection in the lung parenchyma. Pleural effusion usually unilateral, but it may be bilateral also. Bronchopleural fistula. There is a fistula between bronchus and pleura. And TB empyema occurs due to rupture of a pulmonary lesion into the pleural space. Pleural effusion presents usually with chest pain and breathing difficulties. The more the fluid in the pleural space, the more the chest pain, the more the breathing difficulties. And it requires emergency attention. On examination, pleural rub and dullness on percussion on the affected side and absent vesicular breath sound. You see, I am giving you a very rare picture of AFB in pleural fluid. AFB in pleural fluid. You see here. It's very rare. And this I got in this institution just 6 or 7 months ago. Now, second important extrapulmonary tuberculosis is lymph node. Lymph node anywhere in the body, but usually cervical, axillary, mediastinal, and abdominal nodes are affected. It usually presents with fever, local swelling, redness, and pain. On examination, it may be single or multiple lymph node, may be matted, enlarged, mobile, tender, but not fixed to the deeper structure. Mind it, not fixed to the deeper structure. This is very important. If it is fixed to deeper structure, you have to think of other diagnosis, not extrapulmonary tuberculosis. Maybe discharging. I am giving you another picture. This is under treatment in our department. A lady, about 35 years age, he came with a swelling at this neck. And you see, at this part, this whiteness, this is some swelling. Swelling is still here. And this area, a bit reddish, look darkish, it's reddish. And this was the original lymph node. This is redness, this is swollen part, and this is area of lymph node. Now, next important or next incidence is GI system. Extrapulmonary tuberculosis in GI system usually presents with pain abdomen, nausea, vomiting, loss of appetite, maybe with distended abdomen, and importantly, chronic diarrhea. Chronic diarrhea may be a good feature to think of tuberculosis of GI system. It, on examination, it feels doughy, diffuse tenderness all over the abdomen, shifting dullness if there is ascites in case of peritoneal tuberculosis. It usually affects the terminal and cecum, terminal ileum and cecum. Liver and spleen is not affected. Liver and spleen is not affected except in case of miliary tuberculosis. and congenital tuberculosis of the newborn child. Now, extrapulmonary tuberculosis of bone and joint. Pott's disease, tuberculosis of spine usually involves mid-thoracic spine. Mycobacterium tuberculosis is reached there by hematogenous or by lymphatic channel. What happens in the vertebral bodies? Actually, anterior erosion of the vertebral bodies, collapse of the vertebral bodies, and it gives rise to kyphosis without scoliosis. That is, it creates gibbous. You can get paraplegia, cold abscess. Of joints, usually hip and knee joints are commonly affected. Tuberculosis of any bone or joint presents with local pain with or without fever. Diagnosis is usually by radiology or by biopsy. Now, extrapulmonary tuberculosis of the central nervous system. Most common is TB meningitis. TB meningitis usually affects the children and young adults. Presence with fever, headache, stiffness of neck, vomiting, irrelevant talk, drowsiness, and convulsion. Cranial nerve may be involved. On examination, you will get neck rigidity, altered sensorium, Carnic sign, and upper motor neuron signs. Next, come to pericardium. Usually presents with low-grade fever, chest pain, dyspnea, and all other symptoms of tuberculosis. On examination, what you will find? Now you will get low volume pulse or pulsus paradoxus, distant heart sound 1 and heart sound 2 in case of pericardial effusion, and pericardial rub in case of pericarditis. Apex beat is commonly obscured. Now here I want to give you a tip. How you will diagnose or differentiate pericardial rub from pleural rub. It's a very pet question in practical examination of MBBS. Now, you ask the patient to hold the breath and you carefully hear the sounds from the heart. If the rub is present, then it is pericardial rub. Because by holding the breath, you have stopped the activity of the lung. So whatever sound is coming, it's coming from the heart. So that rub is also coming from the heart. Now come to tuberculosis of kidney, ureter, urinary bladder, and others. Renal tuberculosis usually presents with nothing but fever, pyuria, hematuria, and mind it, sterile urine in culture, sterile urine in culture. At a late stage, there is multiple cavitation in the lung parenchyma. Ureter and urinary bladder may be infected by tubular spread of the Mycobacterium tuberculosis from kidney, and that may cause urethral stricture. Except these three, prostate can be infected. I have seen 1 or 2 prostate tuberculosis in my life, and one of them is in this institution. Seminal vesicles may be affected. Epididymis tuberculosis is very common in our country, and that is one of the major reasons for male sterility. Diagnosis is made by urine culture for AFB, not by any other means. Extrapulmonary tuberculosis of skin. I will give you only 3 examples. Lupus vulgaris. It's a post-primary infection, presents as a red-brown nodule, usually on the head or neck or buttock. Scrofuloderma. If infected lymph node spreads to the skin, causing ulceration, scarring and discharge, then the whole thing will be called as scrofuloderma, and it is most common in children. Tuberculosis verrucosa cutis, a warty lesion on a cold erythematous base. Usually any erythematous area is a bit high temperature origin, but here the erythematous base will be cold, not of some temperature. This occurs as a direct inoculation of the skin. Now come to a very important subject, miliary tuberculosis. Though it is decreasing nowadays, but still we can get miliary tuberculosis. It results at widespread hematogenous dissemination of the primary infection. Involves almost all the organs of the body. Is most fulminating in children, usually presents with fever, anemia and splenomegaly. Sometimes may come with jaundice. It takes about 4 to 6 weeks to get radiographic changes. What are the radiographic changes? That's uniformly distributed, soft, fine nodules throughout both the lungs. Sputum for AFB usually negative. In case of children, you can go for bone marrow biopsy, which is positive in about 2/3 of the cases, but it is very difficult to get the permission of the parents of the children. And actually, this is a clinical diagnosis. You have to observe the X-ray and you have to get a very good history. Then only you can get or diagnose a miliary tuberculosis clinically. Let's go and see. You see this X-ray first. On both the sides, there is very small shadows are there, uniformly from apex to base. You come to one, I am giving you a breakdown picture. You just note the size of the shadows. Just note the size of the shadows. And this is uniformly distributed on both the lung from the apex to the base. Why it is miliary? Now it is actually due to the shape and size of the millets. This is, or all these are millets. And you compare. You just compare the size, shape of the shadows. This is miliary tuberculosis. You again come to this single X-ray. Now, as there is miliary and uniformly shadows all over the lung fields on both the sides, you have to think of some other disease simultaneously. As for example, from infection, you have to think of tuberculosis, cocci iodomycosis, blastomycosis, histoplasmosis, and chickenpox. Sometimes dust or dust-like particle inhalation also cause this miliary shadows in both the lungs, like tin, barium, beryllium, silicosis, even in coal miners' disease, bronchiolitis obliterans, alveolar microlithiasis, hyaline membrane disease, metastasis, histiocytosis, hemosiderosis, psychosis, secondary hyperparathyroidism, and amyloidosis. And of these metastases, lung metastasis usually comes from GI tract, thyroid, kidney. So you have to consider all these differential diagnosis in case of diagnosing ameliorate tuberculosis. Diagnosis. How to make a diagnosis of tuberculosis? First, history. Second, X-ray chest, TA view. Then comes laboratory investigation. Then, if required, CT scan of thorax. But I will not go through the CT scan of thorax because in India, if you have got good knowledge and have got good experience, sputum and chest X-ray is enough to diagnose a pulmonary tuberculosis, no need of HSCT thorax. And that is why I am asking for clinical experience of the physician also. This is very important. Now go to history. First, the age. I told you last day that tuberculosis affects mostly the productive population of the country, that is between 25 to 55 or 54 years of age. The most valuable population of a country, of the society, and also of the family individually. Now, occupation. You have to remember, especially in Indian scenario, there are some occupation other than health workers. This is very important. In case of West Bengal especially, jute mill worker, BD worker or BD binding worker, coal miners, and the farmer working in the jute production. These occupations must be kept in mind. Even the people who are breaking stones just by hammers, not by mechanical procedures. Next comes the addiction. Addiction history is also very important. The drug or alcohol or ganja, all these people are more susceptible to develop tuberculosis than others. Economic status. I am not going to tell you anything about the economic status. You know, the lower the status, the more the chance of attracting tuberculosis. Now, most three important points are coming now. Past history of tuberculosis. However years has gone after the first attack of tuberculosis, it may be 10 years, 15 years, 25 years, still it is important to know the past history of tuberculosis. History of contact. That means if he has come in contact, especially recently, with a family member with tuberculosis, or a co-worker, or some other neighbors, in case of students, classmates, like things. History of contact is very important. And in case of past history of tuberculosis, then the duration of the treatment is essential data to assess or diagnose a tuberculosis. You know, the patient who has got a less than 6 months treatment is more prone to develop or relapse. Actually, if you are not going with the drug therapy for the requisite period, there is always chance of relapse of the disease after some years. Even it may lead to drug-resistant tuberculosis. So the history of tuberculosis treatment in the past, and don't ask by this word, have you completed the course? Never ask the patient, have you completed the course? You always ask, how many months you have taken anti-tubercular drugs? How many months you have taken the anti-tubercular drugs? And also, we want to know the history of diabetes, HIV, chronic renal failure, and COPD. Because its presence will attract tuberculosis, its presence will modify the course of the disease. Now I am going to show you some X-ray. You see this X-ray. All these shadows bilaterally. It's a bit more on left apex than on right, but it's bilateral. This is a classical picture of tuberculosis. Now, before coming to some X-ray, from this X-ray I am going to tell you a few points about X-ray. What to expect in a case of tuberculosis in chest X-ray PA view. Number one, this type of soupy opacities, unilateral or bilateral, more oftenly on the upper lobe, then the mid lobe, lower lobe, rare. Number one. Number two, cavity. Number three, for pleural effusion, a whiteness, some part with a uniformly concave line. Sometimes you will get number four, the fibrosis. Let's see. This is a classical picture of tuberculosis, bilateral. Now, come to this point. Again, here also, this area, you see, this part this white part is opacity, and this area, this is clearing. There is some clearing, not clearing. There is in this whole opaque area, there is a area 1, 2, and maybe here it is 3. Here the opacities are clearing. This means there is a formation or a cavity is in the process of formation. The cavity is in the process of formation. Now then, what looks like, or what's a cavity? You see this. You see this is an oval shaped thick walled cavity. You note the thickness of the wall. This is the thickness of the wall, and inside is the cavity. This thickness of the wall you have to compare when you will get pulmonary bullae or simple pulmonary cyst, where the wall thickness is very thin, specifically in the pulmonary bullae. So you have to remember this thing. The thickness of the wall is one most important point to note in a chest X-ray. Now, pleural effusion. You see, in this marked area, here this is the opacity. This is the opaque area, opacity in the upper region. And in the lower, you see, here is a, you see, let's see. This is a concave line going on. And here the fixed opacity, this is the pulmonary lesion, and this is pleural effusion. In pleural effusion, you will get this type of line, not a horizontal line. A horizontal line means there is a air above the fluid level, and that pressure of air is causing a horizontal line, direct pressure. That is what we call, so that will be a hydropneumothorax. Below you will get the fluid, and above the horizontal line you will get the air. But in pleural effusion you will get a curve like this, and there will not be any costophrenic angle. CP angle will be obliterated. These two things are you have to note in case of pleural effusion. Now come to laboratory investigation. Presence of AFB, that is acid-fast bacillus, at the site of infection is the best way of diagnosis tuberculosis in any part of the body. First, for primary pulmonary tuberculosis, sputum smear for AFB, sputum culture for AFB. Others, you can go to smear from the gastric aspirate, pleural effusion, pericardial effusion, peritoneal effusion, CSF, and you can go for culture with all these fluids and sputum also. Sputum. Sputum means not spitting, but coughing out the mucoid material from the lower respiratory tract. Sputum is to be collected after washing mouth without toothpaste, but before breakfast in a sterile container. Auramine rhodamine stain is more sensitive than Gill-Nielsen stain in fluorescence microscopy. Sputum culture can be done in solid media, which will take 6 weeks time, or in liquid media, it will take 3 to 4 weeks time. Now again I am showing you the picture of rod-like Mycobacterium tuberculosis here or here, the multiple. In Jagannath stain. Looks like rod in red color. And this is under fluorescent microscope. These small reddish yellow structures will show you under the fluorescent microscope on a green background. Now, what others look like AFB other than Mycobacterium tuberculosis after staining? You have to know this. Again, this is a very pet question for practical examinations. A. Food particles. B. Mycobacterium leprae. C. Mycobacterium kansasi. D. Nocardia. E. Spores of Bacillus subtilis. In wool and cotton, fibers may give rise to look like MTB. Now come to CBNAT, next investigation. CBNAT means cartridge-based nucleic acid amplification test, CBNAAT, cartridge-based nucleic acid amplification test. Done in smear negative cases, defaulters, that is, who have not completed the course or irregularly used medicine, suspected multi-drug resistant or all-drug resistant cases. It is identification of mycobacterial DNA. It is identification of mycobacterial DNA. Not the DNA, not the mycobacterium itself, mycobacterial DNA. It gives information about rifampicin resistance other than the presence of AFB. CBNAT usually done from sputum. Any body fluid, that is pleural, pericardial, peritoneal and cerebrospinal fluid, it can be done, except stool and urine. But from body fluids, its specificity is only 10%. If you want to do CBNAT from a histopathological specimen, you have to grind and paste it, then send for CBNAT. Histopathology or FNAC. Presence of granuloma with caseation, epithelioid cells, Langhans giant cells. Both the cells derived from macrophages. Both the cells derived from macrophages, along with lymphocytes and some fibrosis. AFB may be found. It is done in cases of extrapulmonary tuberculosis, as in lymph node, intestine, uterus, kidney, skin, prostate, or epididymis. Body fluid test. There is peritoneal or pleural or CSF, cerebrospinal fluid test. What are the tests done? Microscopy, total count, there is total count of cells, differential count of the cells, lymphocyte count will be very high, AFB may be present microscopically. As I show you, presence of AFB in pleural fluid, biochemistry. Protein, it is of exudative nature, it is more than 3.5. ADA, sugar and LDH. Now come to ADA. This is the most important test nowadays from the body fluids. It's adenosine deaminase. Adenosine deaminase. ADA involved in purine metabolism. It converts adenosine to inosine, found mostly in lymphocytes and macrophages. ADA increased due to stimulation of T cells by mycobacterial antigen. Now you see the levels of ADA in body fluid. Most important, pleural fluid. ADA should be more than 40 unit per liter. In ascitic fluid, it should be more than 36 unit per liter. And cerebrospinal fluid, it should be more than only 10 units per liter. 10 units per liter. Serum ADA should be more than 54 units per liter. Other tests: culture in solid or liquid media, tuberculin skin test with PPD, that is purified protein derivative, done as a complementary test in cases of children. Interferon gamma release assay, again not recommended as a routine test. Molecular test, line probe assay, and drug sensitivity test. Serological tests are banned. Serological tests are banned, and it's not to be taken as a diagnostic tool. Other helpful tests: ESR, it will be high; CRP, it will be high in case of tuberculosis; and hemoglobin will be low in case of tuberculosis. Tests to rule out comorbidities: fasting blood sugar and HbA1c to rule out diabetes or to assess the nature and the status of the diabetic at the time of diagnosis of tuberculosis. HIV 1 and 2, specifically in people living with HIV or PL-HIV and AIDS cases. Urea and creatinine to rule out or know the state of chronic renal failure. Liver function test, that is to know the hepatic disorder, because you know most of the antitubercular drugs are hepatotoxic. So it is an important tool to know the status of the liver function at the start of the treatment and during the course of the treatment. And as patients are coming from low socioeconomic status, sodium and potassium should be evaluated. Thank you very much.